Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, a general surgeon from Indiana. This show is tailored around the nuts and bolts of rural general surgery practice. You will find topics such as practical surgical tips, rural lifestyle, finance, training, practice models, and more. We have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. If rural surgery is your passion, this show is for you. So, now that the ChloraPrep has dried, let's make our incision. Welcome back, listener, to another episode of the Rural American Surgeon Podcast. I'm your host, Dr. Randy Lehman, and I have with us today Dr. Benji Smith. He is doing a fellowship in ERCP in Louisville, Kentucky, and I'm so glad and excited to have a chance to talk to you today, Dr. Smith. Thank you.
Oh, thank you so much for having me. I'm excited to chat with you too.
Yep. So tell me a little bit about, first, an introduction of yourself, your background, and what led you to where you're at now, and then what you're planning to do with it in the future.
Yeah. So, I was born and raised in the upstate of South Carolina. My dad's a surgeon and his dad's a surgeon. So, and I always loved doing stuff that my dad did. So I kind of figured I'd follow in his footsteps. And sure enough, I enjoyed, all the biology stuff in college and went to med school and enjoyed that and enjoyed my surgery rotation. And I luckily matched and close to home in Greenville, South Carolina, a general surgery program there. And I was just very happy to be there and be close to family. As far as the endoscopy stuff, as you know, you don't always get a lot of positive feedback as a resident. And after doing about 10 or 12 colonoscopies with one of my attendings, he sat me down and said, you have a natural talent for endoscopy. You really shouldn't let that go to waste. And that's, don't get a lot of positive feedback. So that kind of stuck with me. There's one of my mentors and attendings trained with this guru in Louisville, who's the ERCP guy and a hepatobiliary surgeon. And I always really loved doing stuff that this attending did. And I just asked him one day, I said, hey, I really enjoy endoscopy. I think I somewhat have a talent for it. And I like doing the stuff that you do. And he said, yeah, I'll make a phone call. And next thing I know, I'm moving my wife and brand new baby up to Louisville for a year.
Yeah. And so where do you think that's going to take you after and it's a 1-year fellowship, correct?
It's a 1-year fellowship. Right now, very heavily focused on endoscopy. Dr. Vitale is doing less surgery as he gets older. There is still some surgery there, but it's a lot of EUS, ERCP, EGD, colonoscopy, for a variety of reasons. So I think for me, it'll lead to a diverse general surgery practice. I do enjoy taking care of, you might chuckle when you hear me say it, but these pancreatitis patients,
Yikes.
with all these, because as you know, pancreatitis can cause a lot of very difficult issues to take care of. But
yeah,
dealing with these pseudocysts and pancreatic duct strictures, and occasionally you have to operate on those people. But a lot of times these days you can manage them with endoscopy. And so I think pancreatitis, will probably be part of my practice. I'd like to start out doing general surgery and as broad of a breadth of general surgery as I can, and kind of see where that takes me. It's interesting to see, because I'm his 41st fellow, so I can look back and see what all the other fellows are doing, and they all have different practices, but they're all doing really cool stuff, and they're all learning new things, and it's cool to see where it leads.
How many of the fellows are doing ERCP?
Pretty much all of them. Almost all of them, I'd say. And in varying quantities, obviously.
Yeah. Did you otherwise go straight through your training?
Yes, I did. I went straight from college to medical school, and then now in residency. I have a year left of residency when I go home. It's the way his availability worked out, and he was also threatening retirement. So basically, if I had waited a year, I might not have been able to come up and do the fellowship. And so that's kind of a long story, but long story short, the program back in Greenville was excited to send me to come do this because it's such a need. A surgeon that can do these things has been shown to be so helpful. And so they were happy to send me up here for a year and then take me back as a 5.
Yeah, that's great. You think you'll find yourself back in Greenville when you're done with residency then?
I'd love to. It's a great healthcare system. I love the people.
Which program are you at?
It's a Prisma Health program in the upstate.
What do you like about the healthcare system?
It seems to be, it is getting to be a pretty large healthcare system, like a lot of them are, but they do seem to take care of their surgeons fairly well. And I think patients are given a very high quality of care, have a lot of resources, and I think patients get taken care of well. So it's nice to see. Of course, I don't know about a lot of other places, but that's the gist I get.
Sure. Okay. Wonderful. Well, you had actually been a listener of my podcast, and you said that we have a lot of things in common. So,
yeah.
But yet you're not really talking about rural surgery. And so could you elaborate a little further on what it is that you and I have in common?
Yeah, sure. Well, firstly, when I was thinking about being on the podcast, I was like, well, I'm not really doing anything rural, and I'm also not really doing surgery. So I am American, so I guess we have that going for us. But I started listening to you through. I heard you on Behind the Knife, and I was like, oh, this guy sounds really cool. And as I was listening, you kind of hit on a few things that are close to home for me, like medical missions. I heard the word helicopter, which I love. I'm a private pilot. Don't fly helicopters yet, at least. And you professed your faith on Behind the Knife, which was pretty cool. At least you implied it. I can't remember exactly what you said, but yeah. As a Christian, I just thought that was really neat that you did that, and I started listening to the podcast. But I think I'm fairly certain we go to the same place in Guaimaca, Honduras.
Whoa!
And from your description of it, it has to be the same medical facility. I went there. And growing up, my dad did a lot of medical missions, and so I'd go there with him. I actually spent a summer there in college when I was kind of trying to decide if I wanted to do medical school or not. And so I stayed down there for several months and with them and loved it. And I've gone back one time since then in med school, but haven't gone since. But when you were describing that, I said that has to be Guaimaca. It's such a unique place. Yep. They do so much great stuff there. Very close place in my heart because of that's kind of where I've decided I definitely wanted to go into medicine for sure.
You know what they need in Guaimaca? A scope tower.
Yeah.
Yeah, for Dr. Smith to come down.
Yeah, I don't think they have any endoscopy capability down there. Yeah,
that's correct. Yeah, I don't know. You got to get the prep too. That's another problem. But figure it out.
Yeah.
Okay, great. Well, I'm going to skip the why is rural surgery special to you, but we'll substitute it for that. So let's move to the segment of our show called How I Do It. Today, we're going to be talking about ERCP as you're in this special fellowship with Dr. Vitale down in Louisville. And I think I might have seen one ERCP in residency on a patient I went over, that I just wanted to check on or whatever, but very limited exposure. So you're going to be opening my eyes. I know there's a side viewing endoscope, and so introducing it theoretically is a little more challenging, probably easy in experienced hands. And then you're getting down into the second portion of the duodenum, and then you're going to identify the papilla, pass a wire, and then instrument the bile duct. But aside from that, what big technical components am I missing?
Well, no, I mean, that's it. It's just a matter of doing each step. So, when you start out, it's hard to get the scope in the mouth, and then it's hard to get the scope in the esophagus. And then, and this is a technique that I think is useful for any upper endoscopy, is, putting your finger in the patient's mouth and kind of pulling the tongue towards yourself. Mm-hmm. And that allows you to kind of slide the scope posterior to the epiglottis and slide down the esophagus, because you're doing it all blind. And so you kind of do it by feel a little bit.
Do you still use a bite block?
Yep, you use a bite block. Almost all of our patients are intubated, and they're prone with their head turned to the right. And so you can look at the ET tube, and that means that you're lined up, because it's a side viewing scope. So if you're looking at the ET tube and you're sliding along that, and when you get to the epiglottis, you just kind of deflect downwards and you pop into the esophagus. It's 95% of the time it's that smooth you don't even think about it. And then in some patients, especially elderly, little old lady kind of patients, it can be a little bit more challenging, or if they have an esophageal stricture or something like that.
Do most of these people have an EGD beforehand to rule out any sort of structure? Like, I'm imagining, what if you had a large hiatal hernia or some other structural abnormality you didn't know about and you were trying to pass a blind scope?
Yeah. No. Interestingly, it's probably a good idea to do one. And in fact, on all of our EUS cases, we do an EGD first, just to really look at the stomach very well, just because the EUS scope is also obliquely viewing. And so that can kind of give you a landmark for, hey, this stomach is this shape and this is how I'll kind of go. But a lot of times for ERCP, we look at all these people have a scan. So I look at that. If there's a big hiatal hernia, I keep that in mind. But we can usually get through it without too much issue.
If a person has prior Roux-en-Y anatomy or some other altered anatomy, can you still do an ERCP? I mean, Roux-en-Y, I guess, is different, right? So
yeah,
but say they had like something else. Maybe they still have a pylorus and they have a GJ or something. Yeah.
If they have, the most common you'll encounter is probably a gastric sleeve. That almost makes it easier, because it's just like it's like a train track straight to the pylorus. The people who have a GJ, the concern there would be that they have a gastric outlet obstruction. So you might not be able to get through the pylorus, but there's nothing stopping you from doing that if they do have a pylorus. The Roux-en-Y patients, you can theoretically get around there with, push interoscopy and stuff like that, but we don't do a ton of that. We do PTCs for a lot of those patients.
Okay. Ever do any rendezvous procedures?
Yep. Yeah, we do a decent amount with interventional radiology. We're actually doing one tomorrow, and we do that for altered surgical anatomy, but also just failed cannulations, which with Dr. Vitale's being so good, it's pretty dang rare that we fail a cannulation. He's really, really good.
Yeah. Oh, I can imagine. He's he's for sure the expert. When you are talking rendezvous procedure with IR, describe that specifically.
Yeah. So let's just say they have a tight stricture and we weren't able to cannulate otherwise normal anatomy. We go into the IR suite and they perform a cholangiogram through the liver with a needle, and then usually just introduce a wire, and it almost always goes very quickly and smoothly, going antegrade. And so you'll see that wire pop out the ampulla, and then we snare the wire, the tip of it, pull the wire all the way through the ERCP scope, and then load a sphincterotomy onto that wire, and then just push that down to the ampulla, and we can perform our sphincterotomy and put a stent in, or do what we need to do, and then we just pull the wire out, and that hole just kind of heals up.
Yeah, there's another type of rendezvous procedure, I think, and I'm talking about somebody that had a Roux-Y, and then you do like laparoscopy. And you bring an ERCP in through, I don't know how, I didn't ever do it. Have you done that?
Yeah, so you can do a like laparoscopic assisted ERCP, I guess, where you find the excluded stomach or the remnant stomach, bring it up to the abdominal wall, and a lot of people put a very large trocar through the abdominal wall into the stomach, and then you can put the ERCP scope through that, or you can just bring up the stomach and cut a hole in it and put the ERCP scope through that and do your ERCP that way. You can do that open or laparoscopic. We don't do a ton of those here, and a lot of that's because we manage those patients with PTCs. We kind of rely on IR a little bit more. That's just Dr. Vitale's kind of trend as he's done a lot of these, I guess. He just kind of has realized that it's less complicated, easier to manage, maybe less complications, just to do it with IR primarily.
Yeah. So what are your most common indications for ERCP?
Classic is stones. I'd love to say that was our most common one that we do. Unfortunately, there's a lot of strictures and malignant strictures, a lot of pancreas cancer, and cholangiocarcinoma, things like that. That's been a fun part about learning EUS also, because you can, patient comes in severely jaundiced from, out in the community somewhere. There's maybe a mass in the pancreas, nobody really knows. We do a ERCP and, stent them, and then put the EUS scope down. You can see the mass there, biopsy it. We have pathology there in the room reading our specimens as we're taking them, and we can diagnose that patient's cancer on the spot and treat their problem. And then if, after they get some chemotherapy, and operate on them and take the mass out. So it's pretty cool to do all that stuff. At least in training, it's fun, and I enjoy it, being the kind of that whole picture for the patient.
Sure. So talk me through. So you're doing an ERCP with stent and an EUS at the same time. I would say most of patients are coming in with painless jaundice. It'd be that'd be like your board,
Yeah.
So say they came in painless jaundice, maybe got weight loss and wasting and things, and you're really worried pancreatic cancer. Probably most of those patients are going to get labs and a CT scan. They're going to show your bilirubin's elevated. And I wanted to ask you specifically how you think about direct and indirect bilirubin.
That's a good question. Dr. Vitale says it can fool you. So he doesn't really care about fractionated bilirubin. Dr. Phillips, who is another surgical oncologist here that trained under Dr. Vitale to learn ERCP, he does care about it, or at least he wants to know it. I'm not sure where I'm at on it. I'm kind of a less is more kind of person, and if their clinical picture lines up with obstruction, then they need the scope and not be fooled by the lab values. But I don't know. I'm sure there's much smarter people out there that will have a much better answer. But that's kind of what I've been doing this year.
Sure. So I do believe in it. Not that, hey, this is my show, so I can say what I want, I guess. But basically, the concept is that direct bilirubin is directly conjugated, is one way to think about it. So it's a post-hepatic bilirubin. Like if you have a bile duct obstruction, then you're going to have a direct bilirubin elevated, as opposed to your indirect bilirubin, which is pre-hepatic. And so it would be elevated with a problem within the liver itself, or potentially overdestruction of red blood cells, things of that nature, something that's before the liver. And the direct is basically a portion of it. There was something else I was going to add to this. The most common reason for an elevated indirect bilirubin is probably Gilbert's syndrome, which is a patient's a little sick and the liver enzymes or the bilirubin bumps a little bit.
Yeah.
So where my listener, being a rural surgeon and my being essentially me, we most commonly are checking bilirubins when we're worried about a patient after cholecystectomy, I would say.
Yeah.
Or we're working up a patient before we go for cholecystectomy, and then you got these bile ducts that are like 7-8 millimeters. They're like borderline, and you don't know. They're not clinically jaundiced a lot of times. So I get it a lot, and I guess if I saw a post-op patient and they had a total bili of like 2.5, but it was a indirect of 2.1 and a direct of 0.4, I would be quite reassured.
Yeah.
But what do you think? Like, would you, not Dr. Vitale or anybody, but would if that was your patient and in basically like 15 months from now you do a gallbladder, it was a hard one, and the next day you get LFTs. I guess first question: are you going to get the direct bilirubin? And if you did, and it was the numbers I said, would you be reassured?
So yeah, in that theoretical, I would be reassured, exactly because of the things that you said. I would be 100% reassured, but I don't know if it would change my management. I'd still be nervous. If I was nervous enough to check their labs and get their fractionated bilirubin and stuff like that, I'd still probably be keeping an eye on them for an extra day or two.
It might change if you fed them that day.
Yeah, that's a good point. Yeah, I might do that.
Clear liquids versus feeding them. It might change, you see it come down a little bit the next day and you might be more. I mean, it does change my management in that regard. So it's not major stuff, and it doesn't change it does change how I sleep at night too, because I'm stressed out less. But.
Yeah.
Fair enough. Okay. So thank you for going down that rabbit trail with me. I now would like to ask you about EUS, and technically, how do you get the biopsy? What are the gauges of the biopsy? How many biopsies do you do?
Yeah, and I apologize to some of your other listeners who might not be interested at all, but I will tell you some cool things about EUS after I answer your question. But so we use two scopes. We use a radial viewing scope, which just gives you a 360 degree. There's no biopsy channel through the radial scope. And we use a linear scope, which it's obliquely viewing, and it just gives you 180 degrees of vision, but you have a working channel. So EUS is, I want to say, a little easier to learn than ERCP, because you basically just park the scope in different spots, and then you essentially memorize what to look for and what moves to do to find the anatomy that you're looking for. And so after you get the hang of it, you say, well, this patient has a pancreatic mass. You go into the bulb of the duodenum, you deflect up, and you're looking right there at the pancreas, and you can see the bile duct come down. If there's a mass causing a stricture of the bile duct, you can see that as a hypodense area, and it's usually not very discrete. You can usually see it right away. And so you introduce the needle down. We use 25 gauge needle a lot, which most GI people now are using 22 gauge or 19 gauge. Dr. Vitale thinks he gets really good samples and less bleeding with the 25, and we diagnose people's cancer all the time with it, so I can't really say one way or the other, but we use a combination of 22 and 25 for that. And you watch I wish I had a video or something. You watch the needle, exit the working channel, and then you set the gauge on the needle to determine how deep you want to penetrate. You want to make sure you're not going through the lesion into the portal vein or something. And then you just take multiple passes, and then that just basically gets a core of tissue that you're jamming into the needle.
Are you applying suction on the needle at this time?
Some people do. We don't usually, but you can. And then we consider this F and B fine needle biopsy, not fine needle aspiration.
Okay.
We just do it without suction, and we almost always not an issue. And then they introduce a stylet down the needle, and it just shoots out all the stuff that's in the needle, and you can look and see if there's any core tissue. And they basically smear that around on a little slide, and then the pathology tech sets it, and then the pathologist looks at it, and you just look at it with them, and you can see there's cancer cells right there, and that's your diagnosis.
They look at it without fixing it in any way, or how do they?
Yeah, they fixate it. That's a good question. They fix it with alcohol, and I think they stain it with, I want to say eosin. I'm not 100% sure. I need to ask them about that.
Yeah.
I had this thought the other day. I was like, I should really know what stuff they use. But anyway,
but it's not frozen.
It's not frozen, no.
Yeah. So because that wouldn't make any sense, because you're trying to do margins for frozen, not a fine needle. So
right.
Yeah, that makes sense. So it is probably H&E then, I would imagine. But
yeah,
very good. So then you got a diagnosis. Now, do most people that are doing this fine needle technique have pathology with them, or is that just a Louisville thing?
It's kind of up in the air right now. There's a lot of research on it, and it's kind of a debated topic in the gastroenterology literature. Okay. And so it just depends, I think. At some of the really big institutions, they just put everything in formalin. And then at some of them, they have pathology there. There hasn't really been a great study in recent times with modern technology as good as it is, and now that we're doing more FMBs than FNA, that really show that that is definitely better. But it is nice to know that you're in the lesion, and it's good for the patient to tell the patient, yes, this does look like cancer, or no, they're seeing only inflammatory cells. They don't think it's cancer, but we'll have to wait till the final pathology. So I think it gives something to the patient. It's probably the worst day of their life most of the time. And so to be able to give them a little bit of something in their family who are, these people are coming from like 3 or 4 hours away in the middle of nowhere in Kentucky. They've never been to Louisville. They have a cancer, maybe. They don't know. They're scared. So I think it's helpful.
Oh, yeah.
The pathologists hate it, but
sure
it's their job, so they can do it.
Very good. What about the stent? Let's go back to a step and say they've got obstruction or for whatever reason. Well, who gets a stent, first off? And then technically, how do you do it?
Yeah, so stenting is also kind of a little debated topic. If somebody has a stricture in their jaundice, they get a stent. But if somebody has got their gallbladder out, cholangiogram showed a stone, you're pretty certain it's one stone. You do your ERCP, no issues, get the one stone out. And you do a sphincterotomy. There's some evidence that shows that you probably don't need to put a stent in that person. We put them in pretty much everybody, and that means you have to go back and take it out. But it kind of gives you a chance to go back and make sure you didn't leave any stones, which is nice, which is definitely what I'm going to do when I start out. So for us, almost everybody gets a stent, unless they've had prior ERCPs and their ampulla is wide open and draining freely.
So let me, for the listener here, so you go down, we'll say it's that scenario you just described. You feed a wire, you can see it coming out, you feed it into the ampulla, then you pass a sphincterotome. And exactly how does a sphincterotome work? And then next, talk me through the stent.
Yeah, so you really engage the sphincterotome. It's kind of a tapered tip, and you engage that in the ampulla. And so when you're engaged in the ampulla, you can either inject a little contrast and kind of see the anatomy, and that'll help you determine which angle you need to push the wire. Sometimes the wire goes straight up, no issue. But a lot of times there's a sharp angulation, or you need to adjust your angle and to really get that wire to go. So you engage the sphincterotome, get your wire up, hopefully that goes smoothly. Sometimes that's the kind of the rate limiting step of the whole thing. And then you push your sphincterotome in a little bit, and there's a cutting wire that's hooked up to basically a bovie. And it's and you bow that sphincterotome so it creates kind of a bowstring effect, and you aim to cut the sphincter, the ampulla, between that 10 and 12 position on a clock, and you can make a pretty generous sphincterotomy without causing much issue if you do it that way. And we use it's a mixed cutting and coag current it's a Irby device.
Mm-hmm. So that means it's going away from the pancreatic duct. Is that why you're putting it 10 to 12?
Yeah, exactly. And there's apparently less blood vessels up there. That's what I'm told. I don't know. We don't get into much bleeding doing that, but I have seen it. But yeah, away from the whole kicker with ERCP is hurting the pancreas, and you can do everything perfect and not touch it at all, and the patient still gets bad pancreatitis. It's very frustrating.
So what's the rate of pancreatitis with the ERCP, and what's the rate of dying from pancreatitis with the ERCP?
Oh, yeah. I quote 2 to 3% for post-ERCP pancreatitis for us. Dying from that, that's tough. I'm not sure.
Pretty rare, though. Way less than 1%, right?
Yeah, it's rare, but it happens. And we get patients transferred in from all over who had an ERCP attempt, and patients do die from it. So it can be extremely serious complication, and oftentimes devastating. And you want to make sure that sometimes the indication for the ERCP wasn't always great too. So we do see some pretty horrific complications from just as straightforward, so it seemed ERCP.
Yeah, well, the lesser the indication, the greater the complication, right?
Yeah.
So you just want to make sure you're there for the right reasons, and you've had a discussion of risks and benefits with the patient. Basically, that's truly informed consent, because what we do is not ever without complication risk.
Yes. Yeah.
So there's always that risk. Okay, wonderful. So then I cut you off though about putting the stent up. So go ahead and hop back to that.
Yeah. So we do a lot of so if we're putting a stent in the bile duct, which is kind of the scenario we were talking about, you kind of size it up on the patient and what their bile duct looks like. We do almost all of them as 10 French, just straight flanged stents. These are plastic, and some people do 7 French, or even 5 French. They put smaller ones in, but we get pretty good drainage with our 10 French stents, and almost everybody's anatomy will accommodate that. That's like 3 millimeters. So you put with the wire up in the bile duct, you put a guiding catheter over the wire, and that's just a small catheter that's less than the inner diameter of your 10 French stent. And so you deploy that kind of in the position that you want the stent to be in. And that has markers on it. So you can say, the markers are 8 centimeters apart. So you can say a 10 centimeter stent will fit well here. Mm-hmm. And then you put the stent onto that guiding catheter outside of the scope. And then there's a pusher, which is just a plastic tube that just that you push down and push.
Is the wire still inside the guider at this time? Okay.
Yeah. The wire's still up. So it's wire, guider, stent, and then pusher. And you just shove that stent down, and you're kind of using the elevator on the ERCP scope to kind of help you maneuver it up. And it also requires your assistant to give some back pressure on the guider, or else you'll just be pushing the guider up and perforate the liver. So they kind of have to be pulling it out as you're pushing the stent in, kind of coordinate it. There's some stent deployment devices and stuff. They basically do the same thing. They're just a little bit, quicker, and for short wire.
So what holds the stent in place?
Those there's a inner flange, so that kind of holds it, and also just we put a pretty big stent in, so it's just kind of pressure of the wall and the ampulla.
Gotcha. Anything else I need to know about stents? So then you take those pieces out, and you're going to come back and exchange or remove the stent in what time period?
Yeah, that's great. So the plastic stents we leave in for about 3 months. They could stay in a little longer, but we go in and do another ERCP in 3 months and repeat everything. We do put metal stents in, which is probably good for surgeons to be aware of, that there can be plastic and metal stents. But we put some metal stents in. Those are getting more common. There's covered and uncovered ones, so there's complexities within the complexity. But the covered ones slide out pretty easy, and we leave those in up to a year, 6 months to a year. An uncovered stent is something a surgeon might hear about, because once you leave it in a little too long, you can't get it out. So
right.
It gets grown in.
So are you doing, I mean, I'm thinking like colon cancer, when we're talking metal stents, then usually that's a palliative care type of an operation. Is that all true for this as well? Like, you're planning on that stent to come out with a Whipple or not ever? Or what's the...
We don't use a lot of uncovered stents, but that would be the case to use one, is if you're not planning, if you're not going to take it out. But we use these covered metal stents that work really well in really dilating a stricture over time. So if they have a tight, benign stricture from pancreatitis or something, or just chronic inflammation from stones, we'll put that in there, and probably after their initial ERCP session, and that helps to dilate that area, because whereas the plastic stents 10 French, these stents expand up to 10 millimeters.
Oh, wow.
Yeah, so they expand. They have pretty high kind of radial force that they put on the.
And they're self-expanding, not balloon expanding.
Yeah, they're self-expanding.
Is there such a thing as a balloon for the sphincter?
Yeah, we do like a balloon dilator or something like that. Yeah, we dilate, and it's just like what you see on vascular or something like that. It's very similar. But we do that for stricture, pancreatic duct strictures, or ampullary strictures, or just a smaller ampulla and a big stone. We might dilate. But anytime you do that, you're at risk for causing some pancreatitis.
Do you do that under fluoro, and do you inject contrast in the balloon?
Yeah, we have contrast in the balloon, and we use a lot of fluoro. So yeah.
Yeah. Okay.
Yeah.
Sure. All right. Anything else that I'm missing technically, or something maybe a surgeon should know?
Yeah, there's, I guess, one thing a surgeon should know, or there's sure lots of things, but one thing is these stents can cause perforations of the duodenum, and we do see that. So if the stent's left out a little long, the part of the stent that's in the duodenum can perforate the back wall. A lot of times they're retroperitoneal, and you just need to go remove the stent and give them antibiotics and maybe a drain or something like that. They might not need surgery, but it can be a surgical issue for sure. And that's something that your rural general surgeon listener might see one day. Hopefully not, but maybe.
Yeah, that's great to know. Very good. Well, this has been wonderful to get a chance to talk through that. I think we should move on to the next segment of our show, which is actually our financial corner. I didn't know if you had a money tip for our listener.
When I saw the question, the devil's advocate in me just had to say something. So we bought a house right at, and when I started residency, and it maybe wasn't the best financial decision at the time, because we found a house that we absolutely loved. It's in a great neighborhood. Everything was perfect, but it was way too expensive. Mm-hmm. And I maxed out my doctor, mortgage basically, which wasn't the best idea, but I do not regret it one bit, because for multiple reasons. We love our house. We love our neighbors. We have great neighbors. It's very safe. It's very walkable. Very lots of good, restaurants nearby, all that stuff. And also, it's gained a ton of value, and we have a low mortgage rate. So people told me to not do it, and then I kept asking people until somebody said, yeah, sure, do it. And then I took their advice. I'm obviously not saying that's the right answer for everybody, but sometimes it does pay off. I don't know. That's probably not the advice you wanted me to give. But,
no, I appreciate it. That's why I'm asking you that question. And of course, I always have my own little twist on it. But a lot of times I tell people, the house that you buy, it determines so many other expenses. And I think the house should be considered a luxury spending item. Anything that doesn't make you money while you sleep should be considered a luxury spending item, in my opinion. And that just is supporting your quote unquote lifestyle. So the thing is, a lot of people will say the house is the best investment they've ever made, because for many people, the house is the only investment they ever made. Right? And the reality is the holding cost of that house is so high that to pay the taxes and insurance and maintenance over the years, it's a forced savings thing, and it will appreciate, with inflation. I'm not saying it can't be an investment for some people. And that's why a lot of the financial pundits don't say that you have to go debt free necessarily on your house.
Yeah.
But the thing is, most people, if I took your current financial situation, it depends, because life is short, and life is not maximize your net worth at the end of however many unknown years that you have to live. That's not the point. And so you make your own decisions. But that being said, take it into just purely finance. If I took the money that was invested into the house, if you could, okay, because you might be a vet and you might not have the opportunity, you might not actually have the money, but you might find some way to leverage this asset when you couldn't leverage anything else.
Right.
But if you leveraged and you invested the same money into something else, like, real estate for investment purposes, for example, and you lived in your parents' basement, you would be financially ahead. Like, there's no question.
Yeah.
But it also depends on how things are managed. Obviously, if you bought a commercial real estate investment and then you lost your tenant and it sat vacant for 3 years, you could go bankrupt by doing that. And if you leveraged against stocks, which most people tell you not to do, you might get a higher return, but you might go bankrupt doing that too. Right. So I am definitely not telling you in this podcast to do any of that stuff. I'm just asking if there's something like generally as far as a principle. And so you have provided us much to think about, sir. And that's my 2 cents on the topic. So very good. Let's move on to the next segment of the show, which is typically classic rural surgery. And I usually ask my guests to tell us a story that your urban counterparts just wouldn't believe. But in lieu of that, any classic surgery story would be great.
Yeah. So, training in Greenville, where I've lived for so long and where my parents live and all this stuff, you will encounter somebody that occasionally, and it probably doesn't happen in a much bigger place, so it's sort of rural. But I went through a phase where I kept seeing all these people that I knew, or that knew me through something, just because of me living there for my whole life. An example of that is, I think I was an intern or second year, and I see, I was just looking at the trauma list, and I see a girl who I went to high school with. Not only did I go to high school with her, but I, went to college with her, and I was good friends with her brother. and her brother married my wife's sister.
Oh, wow.
And so when I saw her on her trauma list, I was obviously very alarmed, and luckily she was okay. Yeah, and then there's been several other times where I think I know this person, and you go in, and sure enough, it's somebody you went to high school with, or that babysat you. One of the nurses there babysat me, for multiple years. So I think that's a really cool part, and you, I'm sure, experience that kind of thing way more than I do, but I think that's a really cool part of practicing where you live and where you lived and grew up, because it means so much to those patients when they see somebody that they know, and hopefully in my case they trust me, but they seem to enjoy it, and it kind of took away from the terribleness of being in the emergency department or being admitted to the hospital with some issue. And you can kind of help your friends out. My wife's, one of her best friend was pregnant, and she called me with a medical concern, and she perfectly described acute appendicitis. And so it was at night, but I just called the in-house resident, and I said, hey, let's get an MRI for this girl. She's going to be in the waiting room in a few minutes, and just get her appendix out, because it sounds like that's what she's got. And sure enough, that's what she had, and she walked right in through the waiting room and got her MRI. And so you can kind of, I called the MRI lady and, kind of sweet talked her a little bit, and she got her right in. So I don't think you can always do that in a bigger place. So like I told you, I think I'm a rural surgeon at heart. I don't know if I'll be able to practice in a rural setting with the things that my life is kind of leading me towards, but I do really, really enjoy those aspects.
Yeah. And so brings up a good question. How close is too close to be involved in the patient's medical care?
That's a great question. I've thought about that several times with all these cases. And honestly, I think you can be there as somebody. I think you should be there, whatever you are, outside of outside of the hospital to them. I really don't think you should be making medical decisions on somebody that that's admitted with an issue. I think there's just no way to get around your bias, and you're going to be blinded towards things. And I really do think you need to, you can still see the patient, obviously, if they're comfortable with that. See them in the hospital, talk with them, help them, discuss things that they might not fully understand. I think all that's fine. And I think you can talk with the doctors, of course, that are taking care of them. But I think you should really try to separate yourself as much as possible from the clinical decision making. I've seen a couple scenarios where things were missed on somebody who was supposed to be getting a VIP treatment, so so I don't know. That's my I don't know if I'll always follow that, but I hope to, because I think they should get the best care.
So let me summarize what you said. If you know the person at all outside of your doctor-patient relationship, you should not be involved in clinical decision-making?
I think if you have a relationship with them, and it's more than just a slight acquaintance. Really, though, as I'm thinking about it, if I knew somebody and they said, hey, will you take my gallbladder out? I still might send them to my partner, who can do just as good a job. I don't know. I'm still thinking through that, but I'm kind of holding firm right now on that one.
Yeah, that's fair. It's fair. It's completely unreasonable for my practice.
Right.
But you have to have a line, and the main thing is, did you hear the story that I told about the case that changed me?
I don't think I've listened to that one yet. I'm sorry.
There's an episode that I put out called "The Case That Changed Me." At the time of this recording, it may not actually be out yet, but it's basically my grandpa had severe acute cholecystitis. Had my partner do it. It was very obvious there that I mean, there would be no way that I would be objective in the middle of that case.
Right.
So the big question is, can you be objective? So, and then the other question is, what are you doing, right? Because if my kid has a big splinter stuck in their foot, I'm not taking them to the nurse practitioner at the urgent care. I'm sorry.
Right.
And so like, am I willing to inject local anesthetic into my, person? Also, even like biopsy of a skin lesion, I would do that on somebody, no question. Getting them now, would I want to actually say it comes back melanoma and say it's my, first degree family member? Would I want to excise that because of the downstream, risks? No, I don't want that on me to, that, did I do the right operation? But what if it's a basal on your grandma? Like, that's fine. What are your complications? It's going to be bleeding and infection. You could have recurrence, but it's not going to be metastatic recurrence. So the question is, can you be objective? That would be my answer. You have to know in your relationship with that person. And if you can't be objective with the complication, then that person needs to go somewhere else. I've got all types, from good friends, family members, to like my buddy's sister's husband's dad, but I know who they are, and I can't now I guess that, do you have them in your cell phone? Like I didn't, but then I ended up like buying a bread spot Sal off of, his son later and stuff. And it's just, where do you draw the line? Now that guy, had rectal cancer, and so I ended up sending him for the rectal resection, but, doing a colonoscopy. See the difference? It depends on what you're doing.
Yeah.
And your risks, like even if I had a colonoscopy, even if I had a perforation, like even if I had the worst complication with colonoscopy, like I could say like, look, I do 1,000 of these and I did it the same and I was objective and I think I could live with that. If I did the rectal cancer resection, because I don't do rectal cancer in my practice, but my friend's sister's husband's dad wants me to do it, then they have a complication. First off, I know in my heart of hearts that I didn't really do the right thing for that guy. No, I wouldn't be able to live with that. So expounded a little bit on it. But I'm not saying what I said is exactly right, but it is how I think about it in my regular practice.
And that's totally a personal, everybody's probably different on that. I know surgeons who've done operations on their significant other,
me too.
I would, but so, and they're comfortable with that. So I don't know. It's just, I don't know. It's an interesting question. I don't know if there's a right or wrong on that, but, I've definitely seen complications from things that you thought would not cause a complication. Now you're in a little bit of a awkward situation.
Yeah. Major case under general anesthesia on a spouse. Do not.
That's rough.
Do not do that. All right. Let's move on to the last segment of the show, resources for the busy rural surgeon. Anything regarding ERCP or any other resource that you'd like to share with us?
Yeah, I think, for the surgeons out there, I think they just need to know who the doctors are that are doing their ERCPs for them. Talk with them, have conversations with them, meet, if you're transferring, maybe try to meet them in person. I think it's important to have a relationship with your advanced endoscopist, and be able to call them on the cell phone, be able to send them pictures from the surgery, and really discuss things with them, because a lot of things kind of can get lost in translation, I think, when somebody's just sent without a conversation. And Dr. Vitale does a great job with this. He gets phone calls from people all over, everywhere, and just to his personal cell phone all hours of the day and night. And he they'll call him from inside the operating room, say, I think I just have a really bad bile duct injury. I'm showing they'll show you the videos as real time. What do you think we're looking at here? What do you think we should do? So having a relationship with the person who's going to do the ERCPs on your patients, I think is important, especially knowing the complications that can happen. Maybe do a little research, make sure this guy has good outcomes before you send all your patients to him, because it matters, and the patient, and especially if the patient's going to have to go back to them, they're going to have to travel to get their stent out or whatever. And so I think that's what I'd say for that. As far as when the question was asked initially, I'd say my resource that I've used the most in training is the tech. So either the respiratory tech when you're in the ICU by yourself, that the RT saves you. When you're learning how to operate, the scrub tech, if you're nice to them and you do the right thing with them, they'll help you out and take care of you. And then this year has been great. The endo techs there, some of them have been doing ERCPs for like 40 years. And they will help you and teach you, and you can learn so much from them. And they're just a blast to work with. If you get along with those people, it just makes life so much better, and they take care of you. But yeah, I've definitely relied on the techs in my life, maybe sometimes more than the attending. So
yeah. Let me ask you 3 bonus questions, if you don't mind.
Yeah.
First question: who gets an MRCP?
Yeah, that's great. It part of it kind of depends on who it is. Sometimes we will get an MRCP when the case isn't clear. You think there could be a stone, but the numbers are kind of equivocal. CT imaging, ultrasound shows kind of borderline dilation. You can't really see, and you don't want to jump and just do an ERCP on. So you'll get an MRCP. It's also helpful for determining mass versus stone. One thing that MRCP is really good at is showing defects in the bile duct. So you get a lot of good kind of contrast there. So if there's a stone there, it'll show it. If it's a mass there, it's really good at showing that too.
MRCPs are non-contrast, right?
We always technically, yeah, but we do them with and without contrast to you get a little bit better soft tissue, information on the pancreas. But
I always get asked every time I order imaging studies, is it with contrast? But then it's by somebody that doesn't know what they're talking about. And quite honestly, I don't know what I'm talking about always, because with CT I do kind of. But there's not a right or wrong answer. And when you say contrast, what are you talking about? IV contrast? Is it omnipaque or gadolinium contrast, or PO contrast, or rectal contrast, or drain contrast? There's like so many different questions there. But I have MRCP available near me, and it has been a non-contrast. So
that'll show you what you need to know if you're worried about a stone or not.
Okay.
The one thing when you do need to, it depends on the patient, but if you're ordering contrast for an MRI, they do a non-contrast run, and then they do one with contrast. And so depending on the scan,
takes twice as long.
Yeah, it takes twice as long. So an MRI, with contrast, they have to lay there on 45 minutes to an hour. So somebody that's kind of spazzing out, they're not going to be able to handle that, and you're going to get terrible images.
Great. Second question: when you go out into your practice, are you going to do routine cholangiogram?
Do you mean on every
lab chole? Yep.
Everyone? No. Just if I'm concerned from labs or imaging.
So what would be your cutoffs for who you would do?
I think when I start out, if they have any transaminitis or a history of pancreatitis, or a dilated bile duct, then I would just do it.
Or bilirubin elevation or not?
Yeah, sure. But if their bilirubin's normal but their LFTs are up,
in any way, like what about an alk phos elevation isolated?
Yeah. Okay. Alk phos is actually pretty sensitive, so that's one I do look at a lot. So
okay, what if they come in an acute cholecystitis type picture and they have AST and ALT 1.5 times normal, alk phos is normal, and bilirubin is 1?
Yeah, so I would starting out, I would do one if I could safely. If not, I'd just trend some labs, knowing that it's probably just elevated because of the inflammation
proximity.
Of that. Yeah, but I hope that I hold by that and actually do it in practice. But I really do plan to be pretty sensitive. I'm planning with seeing all the things I've seen, my gallbladders are going to take a little bit of time. I'm not too worried about cranking out a 15-minute cholecystectomy with all the terrible injuries I've seen. So
I understand. And last question, who gets an ERCP first in the ivory tower of Norton's, we'll say, versus a lap chole if you have LFT elevations, or would they always get a MRCP first?
Yeah, no, we try not to get MRCPs on everybody. We try not to do many at all. In fact, it takes forever to get one, so it's kind of a pain. But we really hold for the MRCP unless we really don't want to do an ERCP and we want to rule out a stone to really put our stamp in it and say we don't need to do an ERCP on this person. But for those patients that come in, if their bilirubin's over 4 or 5, we're going to probably do an ERCP first, and then put a stent in. And general surgery likes that, and then they'll take the gallbladder out the next day, or we'll take the gallbladder out. But if it's mildly elevated, a little, and maybe imaging shows maybe a little something in the distal bile duct or something like that, we'll ask them to do the lap chole and flush things through, or try to, which seems to never work. I don't know if you have better success. But
I never get it to work flushing it, but I do laparoscopic common bile duct exploration. Yeah. And I want to ask you a fourth question about that. But let's get there. So at Mayo, we had GI doctors. I don't know how your relationship with general surgery is better because you guys are general surgery. Yeah. But we had GI doctors and we had general surgeons, and there was always this pushback. Like general surgery would say, the bilirubin's like 2.5 and
they need an ERCP.
The bile duct's 8 millimeters. They need an ERCP. And then GI would say, no, they don't.
Yeah.
And then it would be this thing. So they developed a interdisciplinary algorithm so that we could take the guesswork out of it until it was close. And it's always the same thing. Like, know the rules, follow the rules, break the rules, just like everything else in life. So our guidelines were a bilirubin less than 4. Now, I don't think there was anything about direct versus indirect bilirubin on that.
No, we have to bring that up again.
and then bile duct size, I can't remember what it was. I'm not sure, actually, or even if it was a thing.
Yeah.
Stone in the bile duct on imaging, that means ERCP. It was not a try and flush it type of scenario.
Yeah.
And there was some elevation, like if it changed from one to another.
Increasing. Yeah.
Yeah. Increasing. It was something like that. I don't really remember, but the point is the rules, when you really understand the physiology, the question is, who are you really concerned about?
Yeah.
And I think you came up with a lot of the same, answers.
Yeah. A lot of it too, not to cut you off. Yeah. A lot of it for us is, well, today we're doing scopes. We can knock this ERCP out. We might be here a little bit later, but tomorrow we have a full day and we have dinner planned. So we know the patient's probably going to need an ERCP anyway, and Dr. Vitale feels like he can do it very safely with a low complication rate. So there's absolutely nothing wrong with the indication. So, and it works out so that we can do it, and it works out with us. So, we'll just, so a lot of times that is what determines when we do it.
Yeah, that's real. That is real life. I completely understand. And basically, though, you guys are not worried about doing an ERCP after somebody has taken out the gallbladder, clipped the bile duct, the cystic duct.
Nope.
Like in terms of providing too much pressure, causing a leak, or anything like that doesn't stress you.
I before this year, I thought that would cause an issue, because we'll even do, like with a balloon, we'll occlude the distal bile duct and really jam contrast in to make sure we're not missing anything. But if you see a little, first of all, I think the clips don't just come off that easy.
It's supposed to hold 300 millimeters of mercury of pressure.
That seems like a lot.
Blood pressure 120, so.
Yeah, then the other side of it is, if they had a cystic duct leak, you'd be putting a stent in anyway. So it treats the problems that you might cause. But I haven't seen myself cause a bile leak by injection yet. I'm sure I will. I have a way of messing up everything in every possible scenario. So.
That's good. Surgery is a humbling profession, and you're exhibiting great humility. I'm sure you're doing great. So last question. I talked to the people that did laparoscopic common bile duct exploration, transcystic, who I trained with. They tracked their numbers for success. And they said, we're shooting for 80% or better of success rate for clearance of the duct, because we're in a place with no ERCP. People have to transport to get this, and often delays and things like that. So we feel like if we're 80%, that would be, we can tell the patient that, most of the time we can clear it. These are our numbers. I guess that's good. But then I went to Grand Rounds, and I had a presentation, or chief conference, and I had to present, and it went down the rabbit hole of my biliary algorithm. And I talked to them about, and I was like close to being done. So they all knew what I was going to do, talking about for 5 years. And I told them how I thought about things. And Dr. Nagorny, who's the big HPB surgeon, he challenged me on that. And he said, hey, what's special about 80%? That's a made up number. I would say if you were successful 20% of the time, you saved that person from traveling. And so I actually had one patient while I was on rotation that was unsuccessful with those guys. And I had to call Rochester to tell them, hey, I need an ERCP. And the receiving GI was not a fellow. It was a doctor that I was talking to as a resident, was very upset until I said, he said, why did you do the gallbladder first? And I said, well, we did laparoscopic common bile duct exploration, but it was unsuccessful. Tone completely changed. And he said, oh, okay, I understand. Well, thanks for trying. And, and then we, moved on with the transport. So that experience and the whole, just thinking about it, right and wrong, trying to figure out what's the best thing to do. It seems like if there's a stone, going and taking the gallbladder out, just because when you send, it's probably not going to come back to you anyway.
With their post-ERCP pancreatitis.
Without even doing because the surgeon at their referring hospital is going to take it out before they leave. That's what I'm saying.
I see what you're saying. Yeah.
So it's wrong to just do it and then not do a cholangiogram and not even try. I do kind of think that, and maybe they won't come back, but and my success rate is I think it's 8 out of 9 actually now that I've been out. Good. So I'm feeling good about that. And I also am selective because I look at the anatomy, and if it's a long skinny duct, then I don't do it, and if it's a short fat duct, then I'm like, I'm pretty sure I can get that. So I guess that's my backstory on how to, and I still don't know what's the right percentage. And I'm wondering, after I told you all that, do you have an opinion?
Yeah, I love laparoscopic assisted common bile duct. And I was, the take back the duct thing, I'm all for it. Really, I'm not an ERCP, purist. I'm just I like the bile ducts. So any way of looking at it, I think is cool. We did them back in Greenville pretty frequently with, we use the spyglass, the Boston Scientific, and with some success. And, there's some cases that it doesn't work for. And, there's like a valve and you just can't get past it, even though you dilate or something. So I think you're exactly right. I think, especially in your setting, you look at, as you've got more experience with it, you can look at the anatomy and say, I should probably be able to be successful here. If there's a bunch of stones in there, it seems chock full. I don't know if it's the best thing still. Another thing, I know we're way over time, so I apologize.
It's okay.
But another thing that I've been seeing is a lot of times there will be a stone, but there's really a stone there because there's a distal ampullary stricture from cancer, and they're getting their gallbladder out because it's distended and they have nonspecific symptoms. Of course, we see these patients because we're kind of funneled down into it, but it's pretty common that we see somebody that had their procedure done to get their gallbladder out, they had cancer all along and they had a distal bile duct stricture, and they were sent to us to maybe get their stone out or something like that. So you have to, just like you were saying, look at this scan really closely and really make sure there's nothing else there, and with the clinical history and everything too, of course. But always kind of have cancer in the back of your mind when you're looking at that stuff. But that's off the path of our spyglass. But I do love it, and I think especially in pediatric cases, could save the kid another procedure. And if the anatomy is favorable, I think that's a good case for it. And in some select cases, I think it's pretty slick when it works, and the patient probably thinks you're the coolest guy ever when they don't have to be transferred somewhere.
Actually, the patient has no idea.
They don't know.
they just know that Dr. Lehman took my gallbladder out, and and I draw pictures and I try to describe what I spared them from and it's how interesting it was, and then all they say is, Dr. Lehman took my gallbladder out. So, you have to carry that with you internally.
Well, there's something just cool about it, and I think that's an okay reason, if you have a good, strong clinical indication also.
Yes.
I think that's fine to kind of do those things. So.
Yes. Well, this has been my pleasure. Thank you so much for agreeing to come onto the show, Dr. Smith. I really appreciate it.
Thank you. Yeah, this has been great. I'll keep listening and keep getting some tips and trips, even though I'm not necessarily a rural surgeon and maybe not even doing all that much surgery right now. So.
Right. Well, a lot of this stuff's obviously applicable to general surgery.
Of course.
Well, thank you very much to the listener as well for being with us for this episode. Very interesting learning about the ERCP fellowship in Louisville and a little procedure that many of us do not do, but often order. And now we know a bit more. So thanks for joining us for this episode. Don't forget to like, subscribe, engage with us on social media. And until the next episode of The Rural American Surgeon, we will see you later.